Hello and welcome to another lecture for my class, PSYC 212, Psychological Aspects of Drug Use and Abuse. As you can see from the title, this is a supplement to Lecture 3A, which means it's basically just a review of the topics that I cover in that lecture that includes a few additional opportunities to think about those topics and some questions to help you practice your knowledge or test your knowledge of those topics. In today's lecture, I'm going to talk about that basic question, is drug use a problem? And I'm going to consider one of the ways that we answer that question. That is, if we focus on the toxicity of drug use. So what are some different ways that we can measure toxicity? There are two broad approaches, as I discussed in Lecture 3A, and as I'll review in this lecture. One is to conduct research in the laboratory, usually experimental research, often with non-human animals, to determine how likely drug use is to result in injury or death of those animals. Another approach is to conduct research in the field, that is to say out in society, at hospitals, in prisons, and so on, and observe, often non-experimentally, the relationship between drug use and the incidence of various injuries, deaths, and so on. And similarly, this gives us a sense of how strong the relationship is between drug use and the types of problems that we're interested in, the toxic risk of drugs. So, is drug use a problem? Well, it depends on how you judge the risk, and one of the ways to judge the risk is to focus on toxicity, the likelihood of injury or death. In this lecture, as I've already said, I'm going to focus on toxicity, which we're just defining here as dangers to physical health that result from use, so the likelihood of injury, the likelihood of death from using a particular drug. In other lectures, I talk about addiction or the risk for dependence on drug. How likely is it for you to become addicted to a drug if you start using it? That's a risk that many people would want to consider if deciding whether or not to use a drug. Finally, I'm going to consider another sort of way of answering the question about drug use and problems. That is, what are some of the social problems associated with drug use? These are risks that occur sometimes for the individual and sometimes for society at large around drug use. So these are three broad ways we kind of answer that basic question, how problematic or how risky is drug use? Again, in this lecture, which is a supplement to Lecture 3A, I'm focusing on that first way of thinking or measuring risk, that is toxicity. So I've said this already, but quick repeat. There are two ways of measuring toxicity. One is to conduct research in a laboratory, again, often experimental research, often with non-human animals. Another is to conduct research out in the field, often non-experimental research, where we observe relationships between variables, including drug use and various types of problems which sometimes occur from drug use, like injury, like death, and so on. So let's focus first on measuring toxicity in the lab. As a starting place for our research, we can note that people tend to respond differently to a given dose of a drug. So if we have a particular drug and we decide that there's an effect we're interested in, an effect associated with that drug, we know that if we give a dose of that drug to a large sample of people, some of the people will report that effect, others will not for that given dose. So again, we might have a drug like caffeine in coffee or tea. An effect of that drug is the subjective sense of being more alert and more awake. So we give a dose of the drug, a standard cup of coffee, a standard cup of tea to a large group of people. Some percentage of those folks will say, yes, I feel now more awake, more alert. Others will say, it's not doing anything for me. By thinking about that variable, the dose of the drug we're giving, and the percentage of the people who report a given effect at each possible dose, we can construct a dosing curve, an effective dosing curve, or ED curve. And a kind of a generic example of one of these would look a little bit like this. On the x-axis, we have drug dose, which ascends from relatively low dose to relatively high dose, which is obscured behind the picture of me. There it is, and I'm back. And on the y-axis, we have the percentage of people in the population who we would expect to report an effect of the drug at that dose. So we might have an effective dosing curve for the effect of feeling awake, for the drug caffeine, and it might look a little bit like this. Probably it does, because at higher doses, a higher percentage of the population report that effect. If you give a really massive amount of caffeine to people, then almost everyone's going to report feeling more alert. If you give a relatively low dose of caffeine to people, maybe most people won't. So that's the basic relationship there in our effective dosing curve. Now, as you might well imagine, in the case of human research, when we're estimating effective dosing curves, we're often using self-report measures. So we might have a questionnaire that's designed to measure things like the feeling of being awake as a consequence of drinking caffeine. And if we're giving a drug like caffeine to people, we're going to ask them to fill out a questionnaire and self-report the effects of drugs, of the drug dose after they've had it. Now, once we've estimated an effective dosing curve for a particular drug, we can describe some interesting features of that curve. So we can describe the efficacy of the drug. That's the point of the curve where it kind of peaks off or stops rising. This would be the dose of the drug above which we don't see a significant increase in the percentage of people who report feeling an effect of that drug. Like the maximum dose that you really need to give, above which you don't see a particularly larger percentage of people reporting effects of the drug. Another feature is the potency of the drug. That's the minimum or smallest possible dose that you can give to at which you start to see people reporting the effect of that drug. So here's our rather generic example again. If we wanted to, we might say, well, up around here, I'm kind of just vaguely highlighting with my mouse. This maybe is the efficacy of the drug, or the peak efficacy of the drug occurs at whatever this dose corresponds to. At about that point, the dose effect curve begins to level off. So giving above that dose, whatever it is, doesn't result in a appreciably higher percentage of people reporting the effect of the drug. And we might say, well, the potency of the drug is around, let's say, this dose. I'm just, again, kind of almost arbitrarily scribbling in here with my mouse, which is to say at about this dose here, that's where we first start to see an appreciable percentage of the population reporting the effect of the drug. Below that dose, some people probably are having an effect, but maybe that percentage of folks is just so small that it's not really clinically very important to us. So again, we've got this dose effect curve, or effective dosing curve, I should say, and we can describe different features of it. Two of those features are the efficacy and the potency of the drug. And drugs may differ. If you have two drugs that are designed to do the same thing, like increase alertness or decrease pain, you can compare them in terms of their effective dosing curve properties. And in fact, that's my question now. This is one of those opportunities for you to practice. Imagine that you're a physician who's trying to choose between two drugs to prescribe. You want to choose the one that will require the lowest possible dose that is still effective. So you look at the effective dosing curves for both of those drugs. You open up your pharmacology manual, your desk reference, and you compare the effective dosing curve for the green pill to the effective dosing curve for the red pill. So here we have the effective dosing curves for our two drugs, drug A, the green pill, drug B, the red pill. And the question is, which drug can be given in the lowest possible dose but still affect the largest percentage of the population? And if we look at these two curves, it's fairly obvious, I hope, that the curve for drug A rises faster. So here's the curve for drug A. It's rising faster than the curve for drug B. That means at any particular dose, let's just say about here, a higher percentage of folks are responding if they're taking drug A than are responding if they're taking drug B. I apologize for my kind of messy writing there, but I'm just trying to use my mouse. The basic idea is, let's say if this dose here, where my line is on the x-axis, is 50 milligrams of whatever these two drugs are, then at 50 milligrams, a higher percentage of people taking drug A report that effect than do people taking drug B. So drug A is more potent than drug B at just about any dose. Maybe at really low doses and really high doses, the potency is equivalent, but at most doses we can look at, more people are getting the effect from drug A than are getting the effect from drug B. So the answer to our question is drug A. And we're not just interested in drug effects, we're also interested in drug toxicity, maybe even especially drug lethality. That's kind of where we began with this lecture. We can take the same principles of effective dose curves and apply them to lethal dose curves. That is, we can estimate the percentage of the population who will die from any given dose of a drug. So we might say, well, what's the percentage what's the dose at which we'd expect 50% of the population taking that drug to die? That would be the LD50 for that particular drug. So here's a lethal dosing curve for a drug, and it looks like an effective dosing curve for the drug, except you can see on the y-axis, we're no longer talking about the percentage of population who report an effect of the drug. Rather, we're talking about a percentage of the population that die from the drug. So we might say, at a given dose, about here, sorry for the squiggly writing, this percentage of the population is expected to die. At a higher dose, about here, again, apologies for the squiggly writing, a higher percentage is expected to die, and so on. And this curve is just describing the relationship between those two drugs. Now, clearly, when we're doing research on lethality, we can't use humans. So we are using non-human animals in this type of research, like rats, mice, and so on, which is challenging, both in terms of the ethics associated with that type of experimentation, and also in terms of just practically scaling up from doses in a rat-sized model to doses in a human-sized model. So there's some real complexity here, but just grant that or accept that we can use non-human models to make lethal dosing curves, which are then applicable to human populations. So here's a question to test our knowledge. Imagine that you're a pharmacologist who's comparing two drugs. You want to know which drug is less toxic. So let's say you're writing some treatment recommendations that'll go into a pharmacology manual. You want to be able to tell doctors and nurses, other people who prescribe drugs, which drugs are relatively less toxic. You've got two drugs here. You want to know which one is less toxic, so you run a series of dosing experiments on laboratory animals. And you get some lethal dosing curves that look a bit like this. Drug A in the green, drug B in the red. Which drug is less lethal? Well, we can see here that for any given dose, I'm kind of using my squiggly writing lines here, for a given dose, let's say about here, a relatively lower percentage of folks taking drug B, let's say this is 50 milligrams, percentage of animals taking drug B, this percentage die. And at that same dose of drug A, a higher percentage of animals die. So clearly drug B is less toxic, it's less likely to produce lethality than drug A at almost any dose. Of course, at relatively low doses of the drug A and drug B are about the same. If you give people, or I should say animals, a really small dose of these drugs, about the same percentage taking drug A and drug B die. And if you give, squiggly lines, if you give a very high dose of these drugs to animals, about the same percentage die, regardless of whether it's drug A or drug B. But across most of these lethal dosing curves, drug A is more toxic than drug B in the sense that higher percentages of animals die. So if we combine the effective dosing curve and the lethal dosing curve for a drug on the same graph, we can describe the margin of safety for that drug. That's just the distance between the effective dosing curve and the lethal dosing curve. It's a way of comparing, for a given dose of the drug, what percentage of the population is expected to report an effect of the drug, and what percentage of the population is expected to die from using that drug. So here's just the same image that you saw in the previous slide. I've just blown it up a little bit. You can see that for a particular dose of a drug, let's say we're using this dose here, whatever this percentage is. That's a dose where we expect more or less 100% of the people taking the dose of the drug to report the effect, and almost 0% to actually die from it. So that'd be a good dose to prescribe. You'd be fairly certain that anyone taking that dose of the drug will get the effect, and almost no one will be expected to die from that drug dose. You might say, well, what about a higher dose of the drug? Well, at a higher dose of the drug, even more or slightly more people will report the effect, but not much more. This drug has kind of reached its peak efficacy, but at this higher dose, now we're starting to see some percentage of the population die from the dose, maybe 10% if you'll allow for my squiggly lines. This drug, whatever this is here, has a pretty wide margin of safety because at most doses on the effective dose curve, we're not really very high up on the lethal dose curve. That's probably a pretty good drug to use because it'll mostly do what it's supposed to and mostly not kill you. At least that's what we'd expect. Good margin of safety. Wide distance, literally, on the graph between these two curves. Man, all this highlighting is getting messy. So here's another question for you. It's an opportunity for you to practice with this idea. Imagine that you're a doctor who's considering which drug to prescribe a patient. When you look at the pharmacological information of these drugs, you notice that the effective dosing and lethal dosing curves are much farther apart for drug A than for drug B. So let's see. Here are effective dosing curves and lethal dosing curves for drug A in the green and drug B in the red. Can you see it now? I tried to minimize my little head image there. Anyway, which drug is safer? Which has the wider margin of safety? Hopefully you can see that it's drug A. There's a bigger distance between the effective dosing and lethal dosing curves for drug A, wider distance. This is relatively bigger distance than there is for drug B. You could use drug B, but at any given dose of drug B, a greater percentage of folks are going to be dying, we would expect, than would be the case if we were dosing with drug A. So this is interesting. I hope this is one way we evaluate the risks associated with using drugs, especially when we're doing laboratory work. Usually we're using non-human animals and we're estimating doses in humans that are going to give us lethality, or we're using humans and we're using self-report measures to report efficacy. A significant challenge, or kind of a wrinkle that comes up, is with polysubstance use. This is just a term to refer to situations in which people are using more than one drug. They're using, let's say, both sedatives like benzodiazepine and also alcohol, or they're combining marijuana and alcohol, or they're combining cocaine and alcohol. Alcohol is often combined with other drugs when people are using drugs. This can be problematic from a pharmacology perspective because it tends to shift the effective dosing and lethal dosing curves, often making them closer together. That is to say, making the margin of safety for drug use much narrower. One of the reasons why people end up going to the hospital with overdoses when they're using drugs is if they're also using alcohol, which tends to just make you much more susceptible to problems with a variety of drugs. And we'll see that in future lectures, I think. So polysubstance use can really throw off our reckoning of margins of safety. And in most cases, if the substance that we're adding to the mix, figuratively and literally, is alcohol, it makes drugs more dangerous to use. So again, here's just an example of me trying to represent that. We could see the effective dosing curve and lethal dosing curve for a particular drug without alcohol and then with alcohol. Again, this is just me trying to represent that. These are curves that I drew. These are not specific examples of real drugs. Okay, hopefully that makes sense. An important point here is that dose effect curves and or effective dosing curves and lethal dosing curves, they're just models. They tell us what is typical for people in a population. We might expect a certain percentage of folks to report the effect of the drug or a certain percentage of folks to die from using the drug, but they don't tell us what's going to happen for every individual. And so there is a level of uncertainty if you are a prescriber and you're prescribing a drug to a particular patient. You don't know for sure what's going to happen to that one patient until he or she actually takes the drug. And of course, if you're a drug user and you're just using a drug on your own, like you're consuming alcohol, you're consuming nicotine, you're consuming some sort of illegal drug, you don't necessarily know ahead of time what's going to happen to you until you begin using the drug. Another kind of interesting or important point is all this effective dosing and lethal dosing stuff just applies to drugs which are legal drugs which are produced by the pharmaceutical industry. If we're talking about illegal drugs or semi-legal drugs like marijuana, for instance, we just don't have a lot of dosing information on these drugs. We don't know what an effective dose of cannabis is, or marijuana is, for treatment of pain. We do know, based on some non-human animal research, that there is this almost essentially no lethal dose of marijuana, so that's good. There's a really wide margin of safety for that drug. But for many drugs, it's just not as clear. What about something like methamphetamine? Methamphetamine is a drug which does have some medical uses. It can be used to promote weight loss. It can be used to help people stay awake. It can be used to help people have greater attention if they suffer from attention deficit disorder. However, it can also be dangerous, even lethal, if taken in too high a dose. With illegal and semi-legal drugs, we just don't have the type of dose research or dosing research that we would like. And this is something that I think I touched on in their previous supplemental lecture. It's that idea, that important idea, as I see it, that science is power. It helps us understand how to use a drug so we can make sensible decisions about how to regulate its use. And there's a lot of interest now in expanding the research on drugs, especially marijuana, so that we can better understand the effective dosing curves for various types of things that we might want to use marijuana for, like pain management, promoting appetite, promoting sleep, and so on. So up to this point, I've been talking about ways of measuring toxicity in laboratory settings, sometimes, often, using non-human animals because we can't give people lethal doses of drugs practically or ethically in a laboratory. That's one approach to thinking about and to measuring toxicity. Another approach is to go out into the field, that is, to go out to hospitals, clinics, prisons, etc., anywhere where people who have drug problems tend to show up, and just observe non-experimentally what relationships exist between different types of drugs, different types of drug use, and different types of problems like overdoses, accidents, and even deaths. So again, as I mentioned, a place that we often go to do this is we go to hospitals. And if you're enrolled in my class, you know that I've linked on our Blackboard site to a video taken in an ER in Dallas. This is from the HBO Addiction series that gives you kind of an example of what it's like working in an ER on a Saturday night dealing with the large numbers of people who show up for drug-related accidents and injuries and even deaths, whether it's alcohol or even marijuana. People get hurt often, unfortunately, when they use drugs, especially if they use them in dangerous or irresponsible ways. And data on these problems is gathered by a large number of agencies who participate in what's called the Drug Abuse Warning Network, or DAWN. This is just an association between different hospitals in most major metropolitan areas where they pool data that they gather on problems associated with drug use. And if you've watched my main lecture, you know that I already covered this. This is just a way of tracking over time the numbers of people who show up overdosed, or who even show up injured, or even show up dead and have been using drugs. Once we have this information, we can compare different drugs to see which drugs are associated with the greatest number of emergency department visits in a given year. This is a slightly old table. You can see its data from 2011. If you squint your eyes, you can see that relatively large numbers of hospital visits are associated with pharmaceuticals, including drugs that are anti-anxiety drugs or narcotic pain reliever drugs, but also some other drugs as well. Not everyone who uses these drugs ends up injured or dead, but many people do in any given year. And comparing this information allows us to judge whether some drugs are relatively more dangerous, relatively more prone to toxicity than are other drugs. Here's a table where you can take a look at similar information that's reported for illegal drugs like cocaine, methamphetamine, and the like. And I guess you'd have to back up the video to notice, but if you did, you'll see that the number of hospital visits, emergency department visits in the year 2011, and indeed in just about any other year I've looked at for abuse of pharmaceuticals, is higher, quite a bit higher than for illegal drugs. So while it's certainly the case that people can get into trouble or even die as a result of using cocaine, heroin, or other illegal drugs, many more people end up having those really unfortunate outcomes from misusing medications like anti-anxiety medications, and especially opioid analgesics. That is to say, opioid painkillers. And actually, this is one of the stories that's been unfolding over the last decade or more. It's the increased numbers over time of emergency department visits associated with the misuse of medications. And you can see some data here. This is from the Substance Abuse and Mental Health Service Administration Drug Abuse Warning Network. That's the DAWN network I mentioned. You can see there in the little caption at the bottom of the graph. And we're just graphing from, or we're tracking from year 2004 up through 2011. Again, the data looks similar in more recent years. How over time, there have been increased numbers of adverse reactions. That's people showing up at hospitals reporting feeling sick or because of using a drug, especially a medication, increased numbers of visits associated with misuse of pharmaceuticals. And there are still, as you can see in the blue line, there are plenty of people who show up because of using illicit drugs, but that line is relatively flat. It hasn't changed a lot over the past decade or more. The lines for adverse reactions and misuse and abuse of drugs have been climbing, and climbing fairly steadily, unfortunately, over time. Now, if you've watched my main video, that's to say lecture 3A, you know that there's some issues with the DAWN data. One is that it doesn't really count alcohol problems as well as we might like it to. Specifically, it sort of undercounts them. If people show up at hospitals or clinics because of overdoses or injuries or even deaths associated with just alcohol, they're typically not counted in this data set. The exception is cases in which people show up who have overdosed on alcohol but who are also taking other drugs like marijuana, like cocaine at the same time. Alcohol, pure alcohol problems are not recorded in this data set, which can create the impression that other drugs other than alcohol are much more dangerous than alcohol is. In truth, alcohol is associated with a lot of injuries and deaths in hospitals all around the country, unfortunately. So we get a sort of a mistaken impression, I think, if we're not careful when we think about alcohol problems and the DAWN data. Another point is that the DAWN data tells us about toxicity in terms of the total number of problems that people have who are using various types of drugs, but it doesn't tell us about toxicity in terms of the percentage of users who have those problems. So some drugs are used not very much at all, like heroin, for example. People do use heroin, but as a percentage of the population, it's pretty small. However, many of those people have problems associated with their drug. Other drugs are used quite a lot, marijuana being an example, and a relatively smaller percentage of those users have problems. So the DAWN data, those counts of injuries or counts of overdoses or counts of deaths by themselves can be a little bit misleading because they don't include information about the number of people in the population who are using that drug. So this is a graph from a Washington Post article I read a while back, which tries to correct this impression by giving you the number of emergency room visits per 1,000 users of a given drug from data in the year 2010. And you can see that, relatively speaking, heroin is more dangerous than, let's say, cocaine, than methamphetamine, than pharmaceuticals, because of the 1,000 people who use heroin, we expect almost all of them to end up in an emergency room sooner or later, which is, of course, very sad. There are far larger numbers of people who use these other drugs, especially alcohol and marijuana, but for every 1,000 users of alcohol, we only expect about 35 of them to show up in the hospital, and a slightly smaller number even for marijuana. So scaling the data in this way per 1,000 users, for instance, is helpful in correcting, I think, that mistaken impression which you might otherwise get if you just looked at the Dawn data. Yet another important point is that Dawn emphasizes acute toxicity over chronic toxicity. And what I mean by that is it's looking at toxic problems, injuries, overdoses, and deaths which occur right away. That is, you take too much of a drug and you overdose and end up in the hospital, or you take too much of a drug and you die. That's very different than problems which occur over a chronic or a long time period. So for instance, cigarette use, nicotine is a drug obviously in cigarettes, and cigarette use is not particularly acutely toxic. It's pretty rare for someone to end up in the hospital from smoking one cigarette. But if you smoke cigarettes over a lifetime, it's a significant source of lethality. It's likely that you'll end up in the hospital with some sort of smoking related injury over time. So if we look at drugs like illegal drugs, and we look at drugs like alcohol, and we look at drugs like nicotine in tobacco, we see that over kind of a long term, a greater percentage of folks are ending up with long-term problems for tobacco than for alcohol and even illegal drugs. Just because because tobacco tends to be associated with these chronic or these long-term problems. Dawn gives us a very immediate or acute sense of problems, which is important, but it kind of misses out on long-term problems, especially those associated with tobacco and nicotine. Okay, well, I hope you've enjoyed this supplemental lecture. I feel like it's been a little bit of a chore for me to record. I'm kind of tired today, a little bit off my game, I suppose. But I hope I spoke clearly and you understood what I was trying to tell you. I do enjoy doing these lectures. I hope you enjoy, or at least gain something from watching them. If you have questions and you're enrolled in my class, you can of course post them on Blackboard. If not, you can just post them in the comment section on YouTube. I try to keep up with those and answer them when I can. So again, thanks for your attention, and I'll be back with more lectures, more supplemental lectures very, very soon. Bye-bye.